Every Friday at exactly 7 p.m., HealthPod is here to enrich your lives. Wow, we are grateful that even this particular evening you're with us. I welcome you to HealthPod. HealthPod is a program centered around maternal health, early childhood development, and other public health concerns. Edwin Austin Muthalas is my name, the host. But also, just to remind you about what we are looking at the entire month, we are looking at vision. How is your eye? Or how are your eyes? Are they in a good form? Are they in their normal form? Are they normal? Is everything okay with your eyes? Is there anything you need to know about your eyes or your child's eyes? Look no further. The source is here, the source of information. And in a special way, I want to welcome our DSTV audience. Yes, Church of Uganda Family TV is on DSTV, channel 375. Therefore, no more complaints. We have got you covered. And this particular evening, we are delighted to have Dr. Naomi Nsubuga. She's a lecturer at the College of Health Sciences at Makerere University in the Department of Allied Health, that is optometry. And then, yeah, she's here to take us through today's topic. But I will not, of course, I will not bump into her. She'll first of all greet us before we go into the details of today's topic. Dr. Naomi, we are delighted that we have you today on HealthPod. Kindly greet our viewers and then we shall go into the details of today's topic.
Yes, good evening viewers. It's a pleasure to be here and thank you to Family TV for hosting us this evening.
Wow. So, Doctor, last week we were with Mr. Dralega and we talked about a lot about the eye. We shared a lot about the eye. He told us how important the eye is. And in today's discussion, I want us to draw it more onto the children. So basically, I want us to look at the child eye health and how it is important. But we shall get back to the problem because days back, it was rare to find children with eye impairments, with vision impairments. I don't know why these days it is very popular. So you're going to give us the background and all that detail that someone out there might be wondering on as well.
Okay, yes. Thank you very much. Yes, it seems like these days you're seeing more and more children wearing glasses.
Exactly.
As if it's something that is new, happening now.
Yes.
But in reality is that there's more awareness now and we have trained more people who can identify these children.
So in this, you're meaning that before, it wasn't because awareness was limited.
Yes, before it was the children were not being assessed or looked for. You know, a child does not know they have a problem. What they see is what they see. They don't know they could see better or maybe they don't have clear vision. They don't know how to explain that. So you actually have to go and look for the children who have a problem. So with child eye health, the programs that we have started working on is primarily around looking for these children. We know that 90% of people with problems live in developing or low or middle income countries. But what people don't realize is that 80% of what a child learns, they learn from their vision. Okay? So we've had children who go to school and they think they are slow or maybe they don't understand and maybe they just don't see. In my work, I have actually found children who have been given medication for attention deficit disorders and things like that. But once you go and check their eyes and give them a pair of glasses and then they can now see the blackboard, then everything settles down. The reason they're not paying attention to the teacher is that they cannot see. So
and no one notices
and
that.
no one will not, and the child will not know or they will not understand that everybody else sees differently from them. So you find that it affects school, it affects their quality of life, it affects their future, because if they don't complete school, their future is limited. Their chance of a good life, quality of life is limited. So, and also children who have vision problems are 2 to 5 times less likely to go through the whole education program. They will drop out, earlier than anybody else because they'll get tired of school. They'll get tired of being told that they're stupid or they're not paying attention.
They're slow learners.
And so you hear of children saying, "For me, I'm tired of school," and this might be the problem. So that showed that we really need to go and try to find a way to support these children And the WHO, World Health Organization, has also seen this problem, and they have been kind of pushing a way forward on how do we support children. A lot of programs for eye health have been around for adults. You always heard about outreaches for cataract surgery,
Yes.
where they'll go and look for people who've got cataract. An adult will know that I used to see clearly, now everything is foggy. I cannot see that well anymore. Then they'll go in and say, oh yes, you have a cataract, you operate on that. But then nobody was doing these things for children. So in about 2012, the International Agency for Prevention of Blindness actually mandated eye care stakeholders, the NGOs, the governments, the ministries of health, for example, to start concentrating on children. And in fact, we had the first child eye health project supported by the IAPB, the International Agency for Prevention of Blindness, was done in East Africa. It started in 2013 and ended in 2016. At that time, I was working in the development world, and actually I was the project manager of that project. And we were working in Kenya, Tanzania, and Uganda. So we went out, mandated by the IAPB, to go out and form a consortium. We actually ended up forming 2 consortia and go out and see how can we implement a child eye health project, where we can go and identify these children and provide services to them.
And at that very point, why is it important that efforts should be put onto child health, eye health?
It's because the difference it makes in their life. They can go to school, they can learn. We can also identify those who have other problems that are not purely vision, but those who have infections, for example, those with the cancer are identified early on. Basically going around early identification. Because the quality of life, you're looking at a child, if they live up to their 80s, if you catch them by the time they are 10 years old, you give them a good quality of life for 70 years. Whereas with the cataract projects, for example, you're getting somebody who's already 70 years old, maybe has 10 years to live, so
or even less.
Or less. So then you're making a smaller impact for them compared to a child whose whole future you can determine by catching them early, into implementing a kind of a project, or trying to catch them early and help them to see, or help them to save their lives. For example, with the retinoblastoma, which is a childhood cancer, eye cancer. Children are presenting when it is too late. The cancer has spread, and there's nothing we can do. So if you go and if you set up a child eye health program, you are able to facilitate the services all the way down to the community to identify these children early. So it involves a lot of work, for example, training the community health workers. Sometimes they're called VHDs. Once you give them that information, how do you simple things? If in the community you work with them, maybe a nurse or a midwife, those who interact with children and babies early on, then they will know what to look for. Already we are fortunate that at birth, they should be screening the student eyes, which they do. They wash and clean the eyes and give an antibiotic, which has also brought down the number of children who are getting those gonorrhea infections during childbirth, or any other infection. So all those things are in place, but then a little bit more should be done. We need to work more with the other child health team to sensitize them and say, hey, look out for this thing. In this project that I mentioned, we actually trained the midwives and the nurses so that when the mothers do their postnatal visits, immunization visits, when they give them that education talk, they add in the eye care component. Look out for the white pupil. You know how people are supposed to be dark, that little black hole that we look through. So if there's something in the back that is not supposed to be there, it's going to appear white. Okay? So we just tell them something simple, nothing clinical or medical. Just say, look at your children's eyes. Is that little black hole white? Does it appear there's something white behind it? If so, refer the child to an eye care worker. Is the eye red? Is there a discharge? So anybody can be able to pick that up. Even the mother can be taught. So if these nurses do that, then the mother will know, oh, if this my child's eye does not have a black pupil there, it is looking white. I need to go to the eye doctor. The eye is red. I need to take to the eye doctor. There is discharge coming out. I need to go. So then that way you've empowered them to move to the next step, to enter the health system and then be able to move to the next level and eventually reach where the eye care providers are. We are very few in the country. So we are not at the lower levels, so we need to get our community level healthcare workers.
Is that really fair that you're not at the lower level?
Well, I mean, you know, with the health, human resources, you know, unfortunately we have not reached the number of eye care providers in the country that we can have eye care workers all the way to the lower level. And you can see even the medical doctors don't go to the lowest level. They will get to a certain point, and then you have your clinic officers, and then you have your nurses running some of those health facilities. So if you go to a health center too, for example, that you don't find a medical doctor there. And even you might not even find a clinic officer there. You probably first come across a clinic officer at health center at the level. So that's the challenge, in that yes, we have all the specialized surgeons, the ophthalmologists, and the optometrists, and whatever at the national and regional levels, but the majority of the population is at the community level. How do we get to them and impact on them and get them to search, to come and look for those services? Because we don't have enough people to reach them at the lowest level.
You don't have enough people. What about the services? Can the services be accessed even when there is no specialist? Like you talked about training the VHTs and equipping them and empowering them.
If you have a program, like now if you have the child eye health program, for example, and the country establishes that, then we can go and train those people. Right now there's a primary eye care manual that the World Health Organization has launched globally, and in Uganda it has been adopted and adapted, and the training is ongoing for the community health workers. So this component of identifying and referring has now been incorporated into that manual. Same thing for teachers. For example, if we are now to go to the school eye health programs, and that again for the reason of lack of human resources in eye care, we work with the teachers. So in some of the projects that we have done, we have trained the teachers again just to identify, are the eyes looking straight, both of them looking straight? Is there white pupil? Is there redness? Is there discharge? If they fail, and then of course we give them a small card to check the vision, and if they fail any of that, refer to the nearest health facility with an eye care worker. And then now the other battle is to set up the referral network. Does the teacher or the school or the head teacher know where the nearest health facility with an eye care worker is? So then you need to have the network between education and health, but also in addition, which we're going to be talking about next week, disability. Yes. So that way, if a child is identified, we see if they're identified in school, they will need to know where to refer them in the health sector. If they're identified in the health sector and they need some help, maybe they can't attend a regular school, then the health facility or the eye care worker needs to know where the new
child has an impairment, and then they go through that chain you've talked about of connecting now to the referral. What are some of the features they use?
Again, we have when you do a program, you have a training component, and usually we have trainings at different levels. So when we conducted that training, we trained the VHTs, for example. They had their own training, very, very basic, which was very similar to what we gave the teachers. Remember, this is an extra assignment for the teachers. This is, but they're the ones with the children, and
most of the time.
And of course, it's also not that easy for us as health workers to go into a school. You are an outsider coming into the school. There's some protection getting that is there to protect the children from outsiders. So once you sensitize the district health officers, inspectors of schools, and it cascades down to the head teacher who assigns the teachers who will be able to do this, through a program you can identify, maybe usually working either with a school nurse or a science teacher who understands the eye and the anatomy and everything. So they will understand what you're trying to do. And then they will be able to maybe do a screening. So we're trying to find out to integrate eye health, not only into child health, but also eye health into school health. So those who are dealing with children, the health of the children, they need to be aware of these eye problems. And also to be able, for example, the nurses to screen them, and also to provide education to the parents about to look for them. So it's all involved in a program where you need to make sure you train those people. So this is where the eye care workers now, you become the trainers, give them the basic knowledge, how to identify any problem, and then they know, and usually work with the local eye care workers so that they have that relationship, and then they refer to that eye care worker. Or the eye care worker can go to the school and screen those who have failed and to do the assessment, be it an OCO or an optometrist or an ophthalmologist. Although the ophthalmologists are much higher level, so they usually get the end point when everything else has failed. Yes.
Wow, this is a very interesting conversation that you don't need to miss. We are taking a short breather. We are coming back, still continuing with our topic, child eye health. It is very important that you pay attention to your child's eye health, because when you do not, you may think this child is a slow learner, yet in actual sense, it is the eyes that are slowing down their learning. And if the problem is worked on, you realize that your child is very bright, or was even more bright than your expectations. That is why we bring you this conversation about child eye health. You don't need to miss this. This is HealthPod, brought to you by Makerere University School of Public Health, only on Church of Uganda Family TV every Friday at exactly 7 p.m. This is the second part of this program, and we are with Dr. Naomi Suga, taking us through this conversation. And before the break, she had talked about how they work with schools and how they work with communities in order to bring the services closer to you as a beneficiary. And in this segment, Doctor, let us look at now the leading causes of vision impairments, especially among children, because you talked about awareness in the previous segment.
Yes.
But yes, much as the awareness has been popularized, but then what is the problem? What causes these impairments? Because we thought days back that eye issues were always for all people.
Exactly.
Yeah. So what are the leading causes?
Yes. So surprisingly enough, yes, that myth has been there, that glasses are only for older people.
Yes, and when we find a young child putting on glasses,
yeah,
we look at it as something extraordinary, something
Absolutely.
abnormal.
Yes, and it's gone back. Even now, we still feel we have parents who we really have a challenge with when we prescribe glasses, and they think that, but this is a child, because they know that previously glasses, most people use them for reading. Older people needed glasses for reading, but very few people needed glasses to see far away. But now with urbanization, education, people are doing more close work, and now we're doing a lot of computer work. Thanks to COVID, all of us were working on laptops and phones and tablets and things like that.
Even learning was
exactly, and for the children. So one of the leading causes of child blindness or child visual impairment, I should say, is refractive errors, ability to see. They are not able to see clearly. And this last 2 years, it has even been worse, because a lot of the children were studying at home, and those who, even though the schools were closed, in some of the more urban and developed kind of schools, the children were assigned homework. They're working on laptops or tablets, or those who were not able to afford those were working on telephones. So there was a lot of eye strain and eye care, straining that is going on the child, because they're reading long periods of time and at a very short distance. So we find that one of the leading causes of that is visual impairment, refractive errors. Also, we have some other causes like children who are born premature. They have what is called retinopathy of prematurity. So the back of the eye, they're born before it completely develops, and then as they're going through intensive care and all that, they need to be monitoring of that. I talked about the cancer before, retinoblastoma. Vitamin A deficiency, you can get corneal scarring. That's the cornea is the window on the front of the eye. Also trachoma in some areas of the country can cause scarring. So when you go to schools, depending on where you are in Uganda, you're going to find different problems. And now that our premature children are surviving, before they never used to survive, we're starting to see a more retinopathy of prematurity, which cannot be handled by a specialized ophthalmologist, a pediatric ophthalmologist. And then also some children have cerebral visual impairment, more of the brain, where the blindness is from the brain, not from the eyes. The eyes look healthy, but the damage is in the brain. So going back to the vision thing, in that when we do some of these child eye health programs and you go to screen, most people when they come in, they think that you're going to find everybody's going to need some glasses because of what they do. Surprisingly enough, yes, even though it is a leading cause of vision impairment, we find a lot of children with allergies. When you go to the rural areas, we find a lot of children with allergies, in that child health project we did, it was the number one problem actually we found. And again, you know, our rural areas, lots of dust, lots of grass, pollen and everything around there. So the children were sensitive to that. And I know sometimes they like to give them a lot of medicine, eye drops and whatever, but in some cases if it is mild, all it takes is to keep, you know, the face clean, wash your face, get a face cloth, put it under cold water and compress to take away that itching. Because some people just have a mild kind of allergy. Those with a very intense allergy, yes, they'll need some more further medication, so they'll need to see the eye care worker for that.
Okay.
So when they go in, we need to assess them. So if they fail the screening, you know, most of you who have been to get your eyes checked have seen the letter chart. So that way where you're asked to read letters. So some people say, well, children, some of them, you know, go to nursery school, go to baby class.
And they read these
they
letters
cannot
on the
read
chart.
letters. They cannot. Because first of all, sometimes they don't know even the letters. So we do, if you go to an eye care provider who is familiar with working with children and is equipped, we have those charts.
Okay. Because for the old people, okay, for the mature people, you use the charts.
We use the letter
where
chart.
you read, and what about the children?
The children, depending on their age, some of the older children, the adolescents, teenagers and above, they can read the letters because by then they are, you know, they're literate, they've been going to school, they're in, you know, primary school. So by the time you get to about P1, you'll probably be able to use the letter chart. If they're not too familiar with the letters, we have a chart where they just have the letter E. And it just changes direction. So you just ask them where the letter E, where the legs, we just say where the legs pointing, because usually you have the letter E looking up or that way. So they just physically point where it's looking, even though they might not be familiar with all the other letters. So the most complex is the letters, then you get the letter E. They used to call it the illiterate chart, but we don't like to use that term. It's not politically correct. So, and then if you find that you have now going to the younger children, then we use symbols. So, because sometimes they know the symbols. I'm going to show you a chart here. So we use symbols like these symbols here. So most children are familiar with these symbols. At least even in nursery school, they will be able to identify some of these symbols. They will know the house. And then depending on where you are, because this is an international card, it was designed overseas. And you find where you go that the children kind of change what they say. So what we would call here, people will look and say an apple, but if you go in a rural area in Uganda, they're not familiar with apples. So the child might tell you tomato, which is also acceptable. So we use this chart and this.
So whether the child calls it an apple or tomato,
yes,
they have identified it.
Exactly, because first of all you go and ask the child to tell you, what do you think this is?
Okay.
Then they'll tell you this is a house. When you say, what is this one? Then they say tomato, then you know, okay, that's tomato. So when you go and test, you're not going to say that you got it wrong because they didn't say apple. For them, the closest thing that looks like this is a tomato. So you go with that. This one can be a square if they're older, or a box, and of course it is a circle or a ball. So first you need to go and interact with the child and ask them, okay, tell me what these pictures are.
Okay.
The older children might be verbal, and they'll tell you, so this is what they have, just hold that for me. So then I'll hold this chart, they'll hold that, and then I'll tell them, what is this? So if they're older, they'll be verbal and they'll tell you, oh, that is a circle, or it's a ball. But if they're younger, as you get down to baby class, they might not be able to verbalize it. So you just ask them, can you show me this one? Do you have it there? And then they will point. So we are doing a matching. But in that matching, all these things are calibrated. I can check their vision. So before, people thought they could not check the vision of a child. But we have the tests that we can do, and we can actually test the vision of the child and see how much they can see and be able to actually write down the vision. So this is what we do usually in nursery schools and early primary, in some areas, especially rural areas where not many children go to preschool.
Yes.
But now, of course, the Ministry of Education has introduced early learning in some primary schools. They've done nursery. So if you go to screen in a primary school, chances are that these days you'll find a nursery section. So you need to carry some of these along with you. So these are specialized visual testing, visual acuity charts for pediatric patients.
Do they keep on reducing in size?
Yes, they do get smaller, as you can see. We start off with very big ones, and then we can get small, all the way down, so that you can see. And we measure this at 3 meters. So we check it at 3 meters. For the adults, we work at 6 meters. But for children, all their testing, we do at 3 meters. So that way we're always a bit closer to them. And with children, you need more interaction. I always tell my students, when you're working with children, make it again. They get bored very quickly and start ignoring you, or they'll start crying. And you don't want that crying bit, because then everything is over. So we kind of work a little bit of close proximity, and then we interact kind of like like the way the teachers are. And also when you're working with those young children, it's good to have their teacher around. That's a familiar person. You're a stranger coming from outside. So we always, at the beginning, when we're finding out if the children know the shapes, we ask the teacher to do that.
Because they're more comfortable with the teacher.
Yes, and they're used to the teacher teaching them things and so when the teacher shows them this, because we usually go and say, okay, tell us the shapes. So now if I stand here and I show them the card, then they're with their teacher there. So the teacher is their comforting person and say, okay, what is this thing? Remember, we practiced this thing before. Can you tell me what it is? They will answer to the teacher. They will not answer to you. They will answer to the teacher. But you'll get your results. So you have to also learn how to work with children. It's for those who are very, very young, who cannot talk at all. Again, they think that we cannot check the vision. So we have special paddles like this with different sizes of gratings. Okay. So what we do, the child sits on the mother holds the child. These are now 2 years, maybe 1 year, even 6 months. We can check. So what we do, we cover this up. So I'm holding this, the child is sitting on the mother, and then what we do, we separate this. And people will also see that if you're watching this thing and if I do this, you're going to look, if you can see, you look where the lines are. You're not going to look at this one. This is boring. You're going to look at that. So the child does not have to tell you anything. They're just you're going to be comparing this.
You see the eye movement.
Yes, we look at the eye movement. So even for an adult who might be trying to lie to you that they cannot see, you just put this there with them, they're going to look where the lines are. And the sizes vary, so as you get to the smaller sizes, it's more demanding, so again you can check their vision. So those are some of the things we use to check the child's vision when we go to test. So regardless of age, even if they're coming to a clinic, we have children who are born with cataracts, we have children who are born with lazy eyes or eye turns, squints. All those also need to be assessed. We need to find out is the eye turn because of the prescription, they have a high prescription, the eye is straining too much, or is it the muscle that is paralyzed? Then we refer to the surgeon who will straighten the eyes out. But yeah, it basically needs collaboration. We need to work with the team who are working on the pediatric health, so that they are aware of what we can do to support those children, and also with school health, the teachers, to see how we can help them, the children in school.
Even as we wind up, what is your recommendations, especially when it comes to child eye health?
Okay. So recommendations, like I said, we need to work together, integrate eye health into child health. So the pediatricians, the obstetricians, the midwives and everything, they need to be aware of what we can do. And they need to be aware how to identify the children who might have these problems. With schools, we work with the teachers or the school nurses, again to help us with the screening, but also to be able to identify a child with a problem, send them in for testing. The Ministry of Education, together Ministry of Health, have a school health policy. We have managed to integrate eye health into that policy. So that way, once it is passed, it will require every child who goes to school to get their eyes checked. As soon as they enter school, that's one of the requirements, that they get their eyes checked. Right now, it's for a few select students who go to schools where they require that. And even then, it might not be a qualified eye care worker who signs that form. So, and also to introduce curriculum, eye care into the curriculum of teachers, community health workers, and nurses. Yes.
Wow. Thank you so much, Dr. Naomi. We are grateful, and I believe our viewers shouldn't miss the next episode of this program, because it will be more educative. Yes, we are looking at the eyes and how important our eyes are from childhood to old age. Therefore, do not miss this show. This is Health Pot, brought to you by Makerere University School of Public Health. And this is Church of Uganda Family TV. Edwin Austin Mukalazi is my name, the host. Remember to watch Church of Uganda Family TV on DSTV, that is channel 375, and all the other platforms, Star Times, GoTV, and free to air, plus our Family TV app. But of course, We also have YouTube, Facebook, Church of Uganda Family TV, that is COU Family TV. Endeavor to follow us, like our page, and follow all enriching content on those platforms. Have a blessed evening. May God bless you.